Chris, thank you so much for that introduction. I want to start by thanking Barbara Stone and Greenville CAN for having me here to talk about this today. It is something that is, such a important aspect of the work that I'm doing, and really started from a point in my undergraduate career where I worked at a summer camp for children with autism. I started working with the younger children who were typically, what most people would call lower functioning, had a lot more interfering behaviors. And so we were working a lot on just their kind of day-to-day daily living skills, those types of things. As I progressed at camp, though, I started working more with our teen leadership program. And that was where I really realized this is an area that we are lacking in terms of supporting children with autism. When we think about the diagnosis of autism, this is kind of what we're looking at. So we've got obviously our core social deficits here, and then the repetitive behaviors that are more observable. Generally, there is some sort of language impairment as well, a lot of times related to their social language, how they're using language socially to interact with each other, with teachers, with adults in their world. But as we see, there are a lot of other comorbid challenges that are either related to their autism-specific deficits and challenges that they have, or separate from, but can be, more intense because they are also dealing with those social challenges of having autism. Now, this part here is what a lot of our early intervention is. Folks, I'm realizing people on the screen can't see my pointing. The social deficits, the repetitive behaviors is what a lot of ABA and our early interventions in terms of speech therapy, occupational therapy, physical therapy are focusing on. How can we address these concerns so that children can be successful in an educational environment, in a social environment? But as kids get older and age out of those services, those mental health services are things that become more important, but we are really lacking. A lot of people aren't providing these kinds of services. And so to really highlight the importance of these services, we see that around 40% of autistic adults and anywhere from 15 to 50% of autistic youth can be diagnosed with depression as well as autism. Overall, we're seeing about 70% of individuals with autism having at least one comorbid mental health concern. 40% have 2 or more comorbid difficulties around those mental health concerns. When we look at something like depression, we see that these individuals are 4 times more likely to experience depression than their neurotypical counterparts, so individuals who don't have autism. When we look at something like anxiety, we're seeing that again in around 40% of youth and 50% of adults with autism. And that again is about 2 times more than we are seeing it in neurotypical populations. When we look at now getting kind of more specific, things like OCD, obsessive compulsive disorders, we're seeing those at around 40% of the population of individuals with autism, where in neurotypical populations, that's closer to about 1 or 2%. But our problem when we are looking at individuals with autism and their comorbid mental health concerns is what we're mostly seeing is observed symptoms. So what other people are seeing in children with autism and then saying, I think this child has depression, or I think this child has anxiety. And the problem is a lot of children with autism have something called alexithymia. And what that is the inability or difficulties with expressing their emotions. So if you have a child with autism who's already, emotionally delayed, socially delayed, and are unable to talk about those internal feelings they're having of depression, of anxiety, it's not going to be diagnosed until someone else looks at them and says, hey, I think we're seeing more things here than just these autism concerns. So we've already got problems here where children aren't able to express their feelings and other people have to see them to diagnose these comorbid mental health difficulties. Here again is just really emphasizing the comorbid challenges that individuals with autism have. So only about 10% of people with autism only have autism, don't have any other comorbid challenges. But we're seeing, right, 24% have at least one, 27% have at least two, and then it starts to come down as we're looking at, 3, 4, or 5 more. But still, that means that 90% of individuals with autism are likely to have some sort of comorbid mental health challenge. And this isn't even including the learning difficulties that these children have, or thinking about comorbid intellectual disabilities, which are also going to be contributing to the challenges that we're seeing. So we already briefly touched on this. We're really relying on, as psychologists, our ability and our patients' ability to describe their feelings, describe what has changed maybe in their life, so that we can say, yes, we clearly can see that you've got the symptoms or meet the criteria for an anxiety disorder or for major depressive disorder. But again, symptoms can be hard to recognize. We have to be observing them and paying attention to these children so that we can see them. And we see that there are higher priority problems, especially in younger children. If we have younger children who are engaging in significant self-injurious behaviors, for example, that's going to be much more priority than figuring out if they have just anxiety, which is contributing to these self-injurious behaviors. We need to address those first before we can say, okay, this is also anxiety, let's figure out ways to deal with that. Or children who have significant language delays, for example. That's going to be much more of a focus in treatment, especially if we're looking at ABA, early speech therapy, than comorbid mood disorders, right? Because we have to be able to address those things that are going to help children be successful in an educational environment or in a social environment. And language is pretty critical there. So when we look at nonverbal individuals or lower functioning individuals on the autism spectrum, again, when we're talking about low functioning, we're generally thinking about their intellectual abilities. Depression and anxiety may look differently. So a child who might be of average intelligence but has depression, you might see the typical signs. They may be locking themselves in their rooms, not eating as much, sleeping more. But for low functioning individuals, it might look like an increase in their repetitive behaviors or more severe self-injurious behaviors in periods of anxiety or periods of depression. And again, if we're looking for behavior change then to diagnose something like anxiety or depression, we also have to know what it looked like at baseline to be able to say, this is a change in what's going on, something new is happening. We can now say, okay, this is related to anxiety because it wasn't there previously. Whereas something like the more core deficits of autism are there more across settings and across time. So the behavior change is so important to be figuring out what is going on so that we can then say, yes, this is a child with autism, but they also have, again, depression, anxiety that we need to be addressing in different ways than we are just addressing the core autism symptoms. So again, when we are seeing children who have those more significant symptoms that are impacting their daily life, diagnostic overshadowing can occur. We might just be focusing on autism, their language problems, and missing the mental health cases. So therapies and interventions for children with autism. These top 3 are kind of what most young kids are getting, what most people think about when we think about interventions for autism. Applied behavior analysis, ABA, is obviously one of the gold standard treatments, what we want to have most children involved in. These children are generally also in speech, occupational therapy, and physical therapy. If they're having comorbid behavioral challenges, their parents may be in some sort of parent training or behavioral therapy. But when we start looking at mental health concerns, things like anxiety, depression, what we really need to focus on is more traditional psychotherapy methods, things like cognitive behavioral therapy, where we really are addressing not only the behaviors, but also the thoughts and the thinking patterns that are attributing or contributing, I should say, to their depression, right? What are ways that we can change their environment? Or how can we get them more behaviorally activated to deal with these symptoms? And then again, how can we address their thinking? When we look at things like third wave CBTs, that's kind of the more modern CBT that has kind of evolved really over the past about 15 years. Things like mindfulness, where we're much more focused on looking at our thoughts, accepting them as they are, and then being able to move past them or address them in different ways, instead of just worrying on how are we going to modify our thoughts or how are we going to change our thinking from negative automatic thoughts that we see in depression and anxiety to more positive coping thoughts. Again, what we really want to do is identify what the treatment goal or need is. So if we're looking at something like a child's ability to focus in class or to be able to sit down and do a worksheet, we may want to focus more on some of these behavioral strategies, unless it's their anxiety about the work that's getting in the way, or their depression about not having friends in school that's getting in the way. We treat those things very differently, and understanding that is critical to the goals that we have and then how we reach those goals. So things we want to consider in adapting more traditional CBT to working with children with autism. To start with, we want to think about their language abilities, their cognitive abilities, and their emotional abilities. So if children with autism already are having delayed language, we want to make sure that we are adapting the treatment that we're having to meet their language levels and their cognitive levels. What might work for a neurotypical 10-year-old might not work for a child with autism who's 10 years old, because they have different levels of emotional understanding or different language abilities. And so it can be something that we want to think about as psychologists to say, okay, maybe I want to use something that's more for a neurotypical 7-year-old, but has more concrete language, for example, so that the child can understand what we're talking about better and use those concepts that are more appropriate for their emotional level, their cognitive level, or their language level. We also want to think about interfering behaviors. So this is where we kind of get back to those core autism symptoms. If children are engaging in repetitive behaviors that are getting in the way of their ability to participate in traditional therapy, we need to figure out a way to either adapt what we're doing or help to modify those behaviors to be more appropriate in a therapy context. And then we want to make sure that we have a lot of parent support and home practice. I'll talk a lot more about kind of what my practice looks like and what therapy will look like if a child comes to see me, but I'm ultimately only seeing kids for about an hour a week, maybe an hour every 2 weeks. And if their parents aren't taking what we're learning in session and supporting them at home, whether it be with worksheets or supplemental materials that I'm giving them, practicing those skills with their child, we're not going to see those skills generalized. One of the biggest things I see is kids in my practice come in and we can talk about the skills and they can show that they know how to use the skills and examples. But then when it comes to talking with their parents, the past week we had that exact same problem happen in school and they didn't change what their behaviors were. So they know what they're doing, they know what they're talking about. We've got to work on the generalization aspect of it. And so these are some of the ways that myself as a psychologist and any psychologist can easily adapt what we've learned as traditionally trained cognitive behavioral therapists to help work with children with autism. And these things are ultimately not that complicated, but a lot of therapists will shy away from wanting to work with a child with autism because they might say, I don't have enough experience working with kids with autism. Or, oh, I wouldn't know what to do in therapy with a child with autism. Well, you do the same things that you're going to do with your neurotypical patients. You're just going to change how you're presenting it. So instead of just talking about a skill, which again, I've got some great examples here I'm going to be passing out shortly, right? How can we use visual supports? How can we get the information through as many different learning channels as we can, whether it be looking at it, feeling it? How can we use tactile ways to learn these different skills? Again, we want to be able to increase the ability of these children to internalize and understand the concepts that we're talking about. I mentioned using concrete language earlier. A lot of times, children with autism can have difficulty with things like metaphor or sarcasm. And sometimes metaphors can be great in therapy until you're working with a very concrete child with autism who doesn't quite understand that metaphor. And so instead of, again, using what you would normally use, right, how can you break that down even more? Almost think of like, explain it like I'm 5 years old. How can you take it to what you want to share, but in a way that that child's going to be able to understand it. Using things like lists can be really helpful. So instead of just, again, talking about skills out loud, how can I put it on a paper, condense it to its kind of most basic form that's going to get across information to help a child be able to take that home with them. It's something they can have in their pocket, on their desk, to look at and remember as either a visual cue to use those skills in different situations. I love incorporating things like videos, social stories into my practice. If I can find a video on YouTube, I can definitely get a kid to watch it. I love YouTube as just a way to get across information, right? Maybe the way that I'm teaching something doesn't quite work, but if I can find a video that'll do it differently or better and a child can interpret it that way, great. You know, and then in terms of special interests, a lot of children with autism do have those special restricted or high obsessive interests. How can I incorporate them into my practice to, again, get this child on board with what we're doing? Because a lot of the time, children aren't the ones that are going to their parents and saying, Mom, Dad, I think I need therapy. It's the parents who are bringing them in. And so it can be really hard to get that engagement. And so ways that I can get their interests into therapy are going to really help with that. So again, kind of just an overview of what CBT is before I dive into how is this done? What do I do? Cognitive behavioral therapy works on two different levels. One, the cognitive level, and two, the behavioral level. So in terms of the behaviors, right, our anxiety and depression can be manifested through behaviors. This goes back to what we say. If we can observe behavioral change, we can say, okay, this may be attributed to anxiety, depression. So we want to be able to address children's behavior, whether it be by increasing the coping behaviors that they have, literal skills. I tell kids, I'm filling up your toolbox. We just got to figure out what tool is going to be the most helpful for you, or helping parents modify the environment to see behavioral change. Now, with the cognitive aspect, this is where we're looking at thoughts and feelings. We want to identify those automatic negative thoughts that are contributing to the anxiety, to the depression, identify what they are, figure out, what I tell a lot of my kids, are these thoughts that you're having true or untrue? Are they helpful or unhelpful? And if thoughts we're having are untrue or unhelpful, right, we want to change them. We want to make sure also that kids are understanding their feelings. Can they describe what their emotions are? We have to start there. If kids can't describe their emotions or know when they are feeling more anxiety, more depressed than they are at baseline, they're not going to know when to use those skills. These two things, though, are really the hardest things to get children with autism to learn and to use. It's much harder when children with autism already have difficulties with things like theory of mind, perspective taking, to look at their own thoughts. It's a whole new way of thinking to tell them you can think about your thoughts. And it's really the part of therapy that kind of takes the longest to do, but ultimately leads to the most change when we can finally address those thoughts. So what does it really look like? What am I going to do when a child comes to me or their parent comes and says, I think my child has anxiety, I think my child has depression? So one thing, we talked about visual supports. I talk about this cognitive triangle in pretty much every single one of my sessions. Now, this one is pretty simple, right? So we've got our thoughts up here, our feelings, and our behaviors. And these arrows really indicate they are all connected to one another. This is the first thing I start teaching kids. We've got to learn that our feelings, our thoughts, our actions can all affect one another. We only have to change one of them, though, to be able to change the other two. So we typically start with feelings. It's pretty, concrete when you're talking about feelings. Can you recognize emotions? Do you know what emotions are? How do you read emotions in other people and in yourself? Then we shift into the behaviors and then the thoughts. Now, this is just one way that I will use to teach these skills specifically to a kid, but maybe a kid doesn't understand this as well. Something confuses them about this diagram. Well, again, I've got another diagram that we can use. So if that first one doesn't work, I'll pull out this one instead. We've got the same things, right? What do we do? Our behaviors. What do we think? Our thoughts. How do we feel? Those emotions. So the biggest thing with working with kids with autism is flexibility. If we as therapists can be flexible in how we are teaching skills or the methods we're using to teach them, we can find a way that our children and our patients can learn. And eventually we can get into here, more complicated diagrams, right? This one's a little more wordy. So I might use this with an older child, maybe a teenager, versus the other diagram I might use for, an 8-year-old. We're teaching the same skills. We're adapting the way that we're teaching it to the child's, again, language level and their cognitive abilities. So we can do the same thing when we look at emotions, right? We might start here. How are you feeling? Maybe I'm just going to have them point to how they're feeling. And it doesn't necessarily matter if they're right, if they're wrong, how it fits the situation. What matters is that we can develop a shared emotional language. So if a child says, maybe I'm scared, but then they're pointing to, let's say like this picture, maybe we'll talk about why they picked that one versus this one, which is what most people probably would pick for scared. And so again, you're working to really assess where are these kids in terms of their emotional intelligence and their emotional knowledge before we move into the more complex tasks. And so again, we start here, right? We're just looking at pictures, pretty simple. Kids use emojis all the time, but we can get more complex now. So this, again, is the same basic kind of skill that we're teaching, but now we've added another level to it. So we've got these kind of core emotions in the middle that branch out to be more specific, more descriptive. And with some of my kids, I might not even get to this diagram. It might be too complex for them, right? We might just stick with the emojis to begin with. But it is so important, going back to just that flexibility, right? If I'm doing this one here and my kids are doing really well, maybe we move on to this one and I realize, ooh, that was a mistake. Now they are way more confused than they were before. That's okay, right? We'll go back to this instead. And I think that's where a lot of therapists start to have that worry of, well, I don't know what to do with kids with autism, right? They get stuck. Or they've taught a skill, 2, 3, 4 sessions and think, well, this is about when we move on to the next skill with a neurotypical patient. But no, they don't realize you might have to take a much longer time with a child with autism to teach that same skill. And again, we talked about restricted interests earlier, or special interests. This is a great way, again, to teach emotions using a child's special interest. So now we've also added another level of knowledge here, right? So this is like an anger scale, right? We're down here, like we're feeling good, but now we're teaching about the different levels of anger, right? We're not just angry or not angry. Maybe when our sister takes our toy, we're a 2, but if our parents tell us we can't play on the iPad anymore, we're a 5. So how can we teach kids to self-regulate their emotions, recognize where they are on this scale, and then use, again, different skills that we've learned based on that level? And the way we incorporate an interest here is super easy. Just having pictures of Mario, right, at different facial expressions to show. Up here, he's like real mad Mario. Down here, he's maybe just a little upset, right? So those things help get kids on board. It'll help them to use these things more on a day-to-day basis. This is an example of a behavioral strategy that we might use. And this is just 3 parts of a progressive muscle relaxation exercise where we will go through the different parts of the body and practice tensing them and releasing them. So again, what we're teaching here, when kids get angry or feeling nervous, they literally, we all do too, feel more tense. But we can teach them what that feels like in a non-anxiety producing situation, just sitting, so that they know, okay, this is what tension feels like. This is what relaxed feels like. With the goal being, when they are anxious, they feel that tension and can force that relaxation. And again, right, this over here, like very complicated. There's a lot of words here. I might not give this whole sheet to every child. I might just give them the pictures where here we're squeezing a lemon in our hands, let all the juice out, and then let it go, right? So again, visuals, seeing what they're doing, physically practicing it in a session, right? Stretching like a cat or tightening up your shoulders like a turtle. So all of these different ways just give kids different levels of learning and different ways that we can adapt a skill that a therapist absolutely knows how to do. Most therapists know about progressive muscle relaxation, but maybe instead of just doing it verbally, again, how can we get it on paper? How can we give it to kids in different ways that they're going to be able to digest better? And when we start thinking about our thoughts, right, what are ways that we can show kids how to change thinking? This is something that, it didn't come up as clearly as I wanted it to, but I'm sure everybody knows what this is over here, a cootie catcher or whatever you guys call them. This is actually a way where we will practice taking thoughts, and this on the right-hand side has different either positive thoughts or negative anxiety-inducing depressive thoughts. So it's a game now, right? We play it with our fingers, we open up a slide and we say, okay, what's the thought? Read it out loud. And then we say, okay, what do we think? Is this thought true, untrue, helpful, unhelpful? And if it's untrue or unhelpful, how can we fix it? How can we modify it? Again, instead of starting just with the thoughts that these kids are having, like you might do in therapy, you may sit there with a patient and they can talk about the difficulties they're having with their partner or the anxious thoughts that they're having in a social environment, and you can just practice it with them, their own thoughts. But again, if kids are already having trouble recognizing their thoughts, thinking about their thinking, this is a great way to externalize it, right? Take it almost now like it's a worksheet. They're going to practice with these thoughts first, get really good at it. Then we can say, hey, you know what? You can do these with your thoughts too. And again, all of these resources that I found are all things that I've just picked up online, found from other therapists who have been working with kids with autism. They are readily available to anybody, just on a few clicks on Google or things like that. So here are some examples of some of the things that I actually use in my practice. And I'm going to pass some of these out. Just going to put a couple on every table where workbooks and cards that people can practice skills are going to be able to learn things in different ways. There we go. So anytime that I can get something like a book, again, something physical that a child can hold, can see in front of them, it's going to help them encode that information. So all my stripes over here, this is a great book just about having autism. For some of my families, they come in and their children already know they have a diagnosis of autism. They have talked about it a lot, and we can be very open about it in session. Some of my children come in and parents have not told them and are not ready to tell their kids. Sometimes parents will come in and want to make that transition. So this might be a book that I'll use to do that. Social detective thinking. This is actually a program developed by, I can't talk right now, Michelle Garcia Warner, and it's an excellent social thinking program. They have so many resources on their website to help kids with autism learn these kinds of social emotional skills. And again, like maybe this book doesn't work. That's why I've got other books, and I will find one that does work, right? We can adjust, again, the language level that we're using, the amount of pictures that are in something, or the amount of words that are in something, where we can find something that a child will be able to connect with and learn that skill at their level. Here are some other examples, again, of some of the ones that I've passed out. The tools to try, there are 2 sets of cards out there. These are, again, those behavioral strategies, right? What can we do when we're anxious? Some of them are simple things, right? Just like tensing up your feet when you're sitting at a desk and then letting them go, right? It might be as easy as that. Or a breathing exercise where we're going to pretend we're a balloon and we're going to fill up the balloon and then let all the air out, right? But if we can find just one that can connect with a child, right, that's where we can start. It's a simple skill that they were able to take home and use and practice. But what's going to be important is finding the one that connects with that child, right? Not every strategy works with every patient. That's especially true with kids with autism. Finding that one that will connect with them is so important. And then books like Starving the Anxiety Gremlin, this is a great book for children with anxiety, not developed for kids with autism, just developed for neurotypical children. But I might be able to pull pieces from this book, maybe not the whole thing, but use an exercise that's in it. for a child. Or maybe I'll have children who are able to do the whole thing. And so it really, again, goes back to just that flexibility, really knowing your patients. And this is why it can often take longer in a therapeutic relationship with children with autism than a neurotypical patient. And so kind of now getting into how can you guys get patients, if you have them, or children, to me. Right now, we don't have our own referral kind of paperwork out there. I'm hoping that we're going to be developing that soon. But if anybody out there does work for a medical practice, it's a part of the EPIC electronic medical record system, or has your own way to refer patients out of your practice to other practices, sending a referral to developmental peds with my name on it is going to be the best way to just start that process. I didn't bring cards or a fax number, so I apologize for that, but DB Peds Prisma, if you just Google that, our fax number is there. What I'm mostly doing, because I am really the only person at Prisma in our department doing this right now, we have to be limited because there are just so many people that need these services. So I'm primarily seeing teens and adolescents, generally aged 12 and up, and we are looking at primary diagnosis of autism. We want to make sure we're meeting the needs of that population because there are a lot of other therapists and psychologists out there doing work with other groups. Generally, again, we want kind of average, at least cognitive abilities, but we definitely need that conversational language. Again, the skills that we're working on when we're doing that thinking or those cognitive modifications, where you have to kind of be able to discuss those things and show that you can internalize that and learn these skills. In terms of comorbid mental health, primarily, again, we're looking at anxiety, depression. I have had a couple patients with PTSD, as well as some with gender identity related issues. Right now, though, most of these patients, I would say, refer to Chrysalis. Chrysalis Health is doing a great job, a lot of really good work with gender identity difficulties. Kind of, again, what does therapy look like? So it will start with kind of an initial diagnostic interview. That's really just me getting a baseline, trying to understand what the challenges are that this child is having. Would they be really a good fit for the kind of work that I'm doing? Again, after that determination of kind of goodness of fit for the program, then we'll have our first session, which is really a goal setting session, figuring out what the parents' goals are and what the child's goals are. And then we will start therapy. Length really depends on kind of how much progress the child is making. Are they adhering to the treatment? Are they doing the homework assignments? Most of my patients right now I've been seeing for anywhere from 8 months to a year. And so that is sometimes how long it can be, which again sounds much longer than you're thinking of kind of, traditional therapy where a CBT might be, 12 to 14 sessions if you're just having, one issue. After that, we will have a couple termination sessions where we kind of prepare the child to say, hey, we're going to be wrapping up soon. You've been doing so good, reviewing all the progress they've made. And then generally about 6 months to a year later, we're going to do a follow-up session just to see how things have been going. If the child's still using the skills, if we need to do a refresher, month. Most people we haven't gotten here yet, though. We're hoping to, though, so that I can open up my wait list a little bit more and see some more patients. So that's all I've got today. Yes, definitely have time for questions.
I'm listening a great presentation to give us an overview of the program. My question for you is, in making an assessment of the individual that you will be seeing, how much of an assessment of the environment that they live in do you make in order to help you prepare for the treatment plan that you're going to have for the child? Because you and I both know often environment drives behavior. So give me a sense of how you make that work for the betterment of the child.
Yeah, absolutely. So again, that first kind of diagnostic interview that I do is not just, what's going on now, what are the biggest problems, but also finding out, family history. What is going on at school? What's going on at home? Have things been changing? I definitely talk a lot with parents at that first session about how there is going to be homework assignments that they're going to have to do and things that are going on at home. Again, that kind of external learning, not just learning what we're doing in our sessions. And thankfully, a lot of that can be helped with me providing parents handouts, worksheets, those kinds of things. But as we really progress through treatment, that's when we start to see a lot more of the kind of family dynamics that are going on. And we definitely address those with parents. So I may take a session where I'll meet with the child for about 5 minutes, but then really focus on the parents and what they're doing at home, where we focus again more on those kind of behavioral pieces, right, in terms of the mental health challenges that are happening. So, what are parents doing when their child is so anxious that they can't get them out of the house or out of their bedroom, right? What are they doing when they're starting homework and the kid's melting down because they're so overwhelmed by what's going on? So we definitely address some of those parenting skills as well. Not as much as focusing on the child and the skills that they're doing. It's something that I hope we can expand on and have more of that kind of, eventually I would love to be doing group therapy where we can have a parenting group run simultaneously with a child group so that a therapist can be working on the parenting skills and then someone else can be working on the child skills.
Because that kind of affects your outcome.
Yes, absolutely. Absolutely. I always make the joke, working with these kids would be really easy if it wasn't for their parents. So any other questions? Yeah, absolutely.
I'm curious, as from my experience, it seems that when you take your child to a doctor, they just give them another prescription. That do many of them come with prescriptions that I would find it hard to find a baseline because they're medicated.
Yeah, so a lot of, I won't say all, a lot of my patients are on medication. Generally, and when we think of those like high numbers of comorbid challenges, right? A lot of my patients also probably have ADHD and are on medication for that. When we look at the baseline, right, in terms of considering them being on medication, ultimately their anxiety or their depression is still problematic on that medication. And so what we want to see is just change from that baseline, regardless of their medication. So a lot of the times too, if we think of something like ADHD, it's one of the easiest ones to think about for medication's benefit. If a child can't even self-regulate themselves without medication to sit down and learn and do something, right? The skills we can give them for executive functioning aren't going to be beneficial. So a lot of times being on that medication can just help us with skill acquisition and with learning skills, because again, there are these interfering behaviors that would get in the way of the work that we're trying to do, or, in a school example, what they're trying to teach them. The medication can definitely have an effect. And I would say most patients I'm seeing aren't necessarily on mood medications, but more so are on the ADHD medications, stimulants, and those kinds of things.
First of all, thank you. This was very informative. That's awesome that you guys are doing this work. What about children that are generally not speaking? Are you familiar with an organization that is kind of delving into that, or is that still kind of lagging behind a little bit?
Yeah, it's definitely one of those things that's lagging behind. Again, when we think of children who are nonverbal, and again, it doesn't mean they can't communicate necessarily. There's not as much information out there. And I, off the top of my head, do not know anybody that's doing that kind of mental health work with those individuals, especially with autism, comorbid. I hope that we will get there one day, especially now that we are seeing higher rates of mental health challenges in younger children. How can we be addressing these across populations, not just in the neurotypical population? But right now, there's not a ton that I know. I hope someone out there knows more than I do.
So 2 questions. Actually, I'm kind of on 2 ends here. I do have a child that's on the spectrum, and then I'm also have a background in mental health. So my first question is regarding my child. He's a younger child, so he doesn't qualify for this right yet, but he does see a developmental pediatrician at Prisma.
Excellent.
So if we felt like this was something that he needed as he got older, because obviously he checks in there, he sees stuff around. Yeah. So if we saw that was something, since he's already in that system, would that need to be a separate referral, or that would just be from?
So yeah, that's a great question. Yeah, if you do know a child who is already seeing someone in developmental peds, have them and you think they might be a good fit, have them reach out to their developmental pediatrician, and they will most of the time they just come to my office and ask me about the child and if I think it's a good fit. But those internal referrals are super easy. They will just literally send it to our psych department and they will get sent right to me. And then I'll be able to kind of review that and start that process.
Okay. Good.
Yes.
And then the second question, do you know of good places for mental health professionals to be trained? I mean, I know there's tons of training out there, obviously, on the spectrum for mental health providers, but for you specifically, would you suggest any specific?
Yeah, so I don't have a ton of specific training. You know, even within my training at my graduate school, most of what we did was focused just primarily on, you know, children overall, or we had a lot of trauma-based classes, and it ended up that the few autism classes that were available, it was me and 2 other people who signed up, and then they would cancel the class because there wasn't enough enrollment. I'm hoping that that's not true everywhere. But what I will say is there is, as you said, a lot of just resources out there available. You know, I feel like all the time I am looking into who is doing new research and reaching out to them and seeing if they have anything available yet. There's a few programs that I know are being kind of developed in the works right now. I, of course, can't think of them off the top of my head. It was a couple months ago that I was looking them up, but yeah, specific trainings, I'm really not sure. I hope that, again, we are moving in that direction. But right now I just, you know, find myself doing a lot of just independent research. And again, taking things that I've learned in working with children with autism and applying it to more traditional therapeutic methods that are available and are widely
It's
used.
kind of common sense.
Absolutely, yeah. Which is, again, where the challenge is, right? You have a lot of therapists who might say, I don't work with kids with autism. It's super easy to just adapt what you're doing, but they hear autism, and this might be more my opinion than anything else, but people hear autism and immediately think of, again, those kind of more pressing autism-related issues and not focus on the mental health side of things.
Thank you.
Am I allowed to make a little plug just hearing your questions?
Go for it.
Is that correct? In my experience, at the Applied Theater Center has been very helpful, but there are some tiny little things out in our community that I guess since my daughter is up in age, that there's different things that we've tried. And that was one that we were pleased with. So Applied Theater Center. Yes.
And if you would like to talk to anyone from the Applied Theater Centers, Dale and Rachel are right there. Or anybody else would like to. Sorry,
But yeah, anyway, and if you have any questions, I mean, you can ask me of our experience. Thank you.
We're also, I'm with Springbrook Behavioral Health, we're also sponsoring the Converge Autism Conference. It comes to Greenville every year, so we'll be having that in the spring. And if you need any individual resources as far as training,
What was that name?
Springbrook Behavioral Health.
When is Converge?
It is in May, I believe, this year. Push it back because of the it's not the TD Center anymore, whatever.
Okay.
It used to be the TD Center. I think it was a scheduling conflict with April, so I think it's pushed back in May.
Well, okay, so I'm gonna do a plug as well. I'm with the nonprofit Walls, and we put on free lunch and learns with neuroscientists, doctors on 9 different professional trainings. If your organization or something would be interested in that, you can let us know and schedule something. Sometimes too, we'll schedule it with a group, and then we'll open it up to the community as well. We are actually able to ask, it can take a while for specifics, but I am gonna kind of talk to our presenters about something with, you know, people with, you know, autism and different other disabilities as well, because as we all know, mental health is a disability as well.
Mhm.
And I think that we forget oftentimes that, you know, we're all human, and, you know, it's like somehow we're forgetting that, of course, people with autism have anxiety sometimes and depression and things, or, you know, any condition or thing, you know, so I feel like it's important. Another thing that we're offering, we're able to host as well, is mental health first aid certification. So I think that we are settling on a time around the end of January that we're going to be having a session, usually have virtual, can also do it in person. We host those. And if you haven't heard of it, it's internationally recognized, like Michelle Obama's taken it as kind of the gold bar standard for mental health training. most professionals get 8 hours, professional development, teachers, counselors, whoever, social workers. And also you get a book, that has all the materials in it and a 3-year certification on first aid. So something really good. So if you guys have any questions, we do a lot of different things around here. My son died by suicide, and this was, we actually are we're a little bit different in our approach and what we do. So I would love you to check us out. We've been here now. My son died about August 22nd, 19. And we just keep moving forward. So we'd love it if you check us out. We're offering a lot of really good services and help.
And who you would again, I'm sorry.
Waltz, WALTZ.com. It should be .org, but I don't know why I made it .com. There was a mistake. We have both. I like somehow started using that one, whatever.
The dates, I'm sorry, are May 16th and 17th. And speaking of developmental pediatrics, Dr. Latwood Shaw is going to be one of our keynote speakers this year. We try to mix local speakers with national and international speakers as well. So she'll be speaking. If anybody knows Tasha Rollins, who's here locally, she'll be one of our local speakers as well. Mentioned Dr. Kutcher. So yeah, we've got some international folks, some national. Yeah. That will be a conference for everybody, but that's the best. Sorry.
In working with neurotypical and children with autism, especially in that early teen stage, I've found that there's a lot of resistance to therapy. So I've always been seen as like a friend that you go see, right? Like that. And so in wanting to make that sustainable change and help them, implement these different strategies, have you had any approaches or different things that have been successful for you in getting them on board, actually, with actually bringing that home and trying it, and still seeing you as a clinician, not just a friend? Does that make sense?
Yeah, absolutely. So, I will say, again, that home practice, having things done at home, that is the hardest thing. And so many times I have patients come in and either don't do their homework or didn't bring their homework or didn't practice things. And so, I really just try to make the sessions that we're having kind of fun, enjoyable, so that they can see the things that they're doing can be fun and can be helpful. And then again, any ways that I can send home a pocket guide, a laminated sheet that they can put somewhere in home to just have that visual cue is generally what I'm trying to do. The relationship kind of boundary there is definitely something that I like to toe the line of, actually. Something that I feel like if I can have them more on board as, seeing me like a friend, someone they can confide in, right? We can shift gears halfway through and shift the tone and practice the skills, which again can make it hopefully, more salient for them to want to go home and do it or want to try it. So, especially with kids with autism, when a lot of times I'm working on social skills kind of in the background of everything that I'm doing, I like to try to balance that. So have the professional role, but also show them the social skills and what that looks like too.
Do you see adults with autism as well?
So yes and no. I would say, kind of the top of at least my line right now. I'm seeing the oldest is a child who's about, or he's not a child, but he's about 20 years old. But again, because we are really so tied in with DBP, that's really the upper limit of kind of where we're going. So I don't see anyone really older than that. And generally, if you're, over 18, I'm probably less likely to start therapy with you again right now, because we're just trying to focus so much on, who we can help. And already, my wait list is, I have 2 or 3 people that are just waiting to see me that I'm still working through a lot of my cases right now. So, all right. So if anyone else has any questions, feel free to reach out to me. I should have had my contact information up there, but my email is christopher.moylan, MOYLAN @prismahealth.org. And that's all on the developmental peds page for Prisma. So I'm